Selamat pagi semua. Saya Dr. Kishen dari Unit Vaskular Surgeri, Jabatan Surgeri HCTM. Saya ingin mengucapkan terima kasih kerana diberi peluang untuk bagi unit kami membentangkan CPC pada kali ini. Saya mengalu-alukan kedatangan semua ke CPC hari ini. So, tajuk CPC kita hari ini adalah A Bite from Everest. Satu kes yang kita jarang dapat kita rawat di negara kita. Jadi untuk berkongsi pengalaman merawat kes tersebut, kita ada bersama kita 4 orang doktor yang berpengalaman sudi berkongsi pengalaman mereka dalam merawat kes tersebut. Jadi untuk memulakan CPC pagi ini, saya menjemput dari unit surgery vaskular HCTM untuk memulakan pembentangan kes beliau.
Okay, Assalamualaikum. Boleh dengar ke?
Boleh.
Boleh dengar? Okay, alright. Okay, Assalamualaikum and very good morning to everyone here today. My name is Hisham from the Vascular Unit. So I'll be presenting a rather interesting case which we got recently, and we would like to share this case with everyone. Something which is rare to be seen here in our country. So just a brief history. This patient presents to you with hand pain for 3 days, skin discoloration, as well as reduced mobility of fingers and numbness over distal fingers. Now, with this short history, what we would like to know what runs in our mind for the benefit of our medical students. When you have such history, short history, having evidence of reduced perfusion to the extremities, what we are thinking is probably acute limb ischemia. Now, acute limb ischemia could be several causes. One of the most common causes is arterial embolism, which could occur because of presence of thrombus anywhere along the heart, the aortic arch, or even in the arteries of the upper limb. Right, could be because of AF or any showering of emboli from thrombus along the vessels. And we could also think because of any progressive narrowing of arthrosclerotic plaque, which eventually leads to stenosis and thrombosis. And the other rare complications causes could be because of any arterial access complication, or could be because of autoimmune disease, Raynaud's phenomenon due to several causes such as scleroderma, SLE. But for our patient, he is a mountaineer. Further history, he has pain and discoloration at both the hands, feet, and cheeks. He experienced the symptoms while climbing Mount Everest, and this was at almost the peak. The peak is about 8,000 meters, and he was around 7,000 meters altitude. And after experiencing symptoms, he was evacuated by helicopter and brought to the nearest hospital. So on assessment, the physical examination, he was alert, and what we see is such hand. So if you look at this hand, you could actually see that both of his hands and feet are affected. In fact, the worst hand is on the right hand. You could see there was cyanosis over the distal fingers. It is dusky. There's also blistering over all the fingers, also at the dorsal aspect of the hand, with some evidence of rupturing of blisters, as well as edema. And there was also cyanosis over the other hand, the left hand, as well as you look carefully at the toes, there's also some evidence of cyanosis. So with this history, with this physical examination, and with the history of climbing Mount Everest, what runs in our mind is frostbite. Now, frostbite is something which occurs in extreme cold conditions. And when we look at this physical examination, we can actually grade the frostbite into several grades. So there are 4 grades of frostbite. Grade 1 being no cyanosis. It depends on the extent of the cyanosis. Grade 2 being at the distal phalanx, grade 3 up to the proximal phalanx, and grade 4 when it involves the carpal or tarsal bones. So looking back at this patient, we can agree that probably the worst hand is the right hand, and we could attribute towards grade 3 or grade 4 for frostbite. So our diagnosis would be grade 3 or 4 of the right hand and grade 2 of the left hand as well as the feet. So just a bit of background on frostbite. Frostbite is a severe, localized, it's a form of thermal injury which occurs when tissues are exposed to temperatures below freezing point for a sustained period of time. And body parts which is most prone to frostbite are feet, hand, ears, lips, and nose. And it is important to remember that frostbite is rather a disease of morbidity rather than mortality, because patients would have long-term implications from the frostbite. And because of that, timely diagnosis is important and treatment is essential to maximize tissue salvage. So a bit of epidemiology. If you look at the studies, it is rather quite rare in some countries, but there's one study in Iran which looks at 1,000 mountaineers, and looking at the statistic, it is quite higher. About 36% of them had frostbite. But one relevant study that relevant to our case is a study that was done in the Mount Everest base camp, which was about a 10-year study. And among patients who was presented to the ED, about almost 3% was diagnosed with frostbite. And men at 30 to 49 years old are at highest risk to get the symptoms. Patients with pre-existing conditions that may worsen tissue injury are those with peripheral arterial disease, renal disease, those who are malnourished, and those who are immunocompromised, such as diabetes, and those who are smokers. And risk factors, the obvious fact is that patients who indulge in winter sports, because with the advent of technology and the accessibility towards hiking mountains, mountaineering at extreme temperatures, the incidence of frostbite has been increased over time. And patients who are homeless, this is particular in patients who have cold temperatures, winter season, where they have inadequate shelter from cold. And those who are at high altitude, those with prolonged duration of exposure to cold condition, high wind, as well as those with alcohol or drug abuse, in extremes of age, as well as those who are immobilized. A bit of pathophysiology. How does frostbite happen? As we know that the cold temperatures would cause vasoconstriction, this would later cause something called as hunting reaction. And hunting reaction means basically it is intermittency between vasoconstriction as well as vasodilatation. And eventually patient will have a loss of, there will be neural impairment, which cause loss of sensation. And because of this extreme cold weather, there will be formation of ice crystals in the extracellular component. There will be electrolyte and pH shifts out of the cell, eventually cause dehydration, damage, and would cause microvascular damage as well as ischemia. And this would eventually lead to necrosis. Now, there are two pathways here. Either patient will be rescued or patient will be left in the cold. What we have shown here is once patient has been rescued, that means a rewarming has been instituted, and what will happen? A rewarming is rather a double-edged sword. It could save the patient, it could kill the patient as well, right? So how does it happen is that with rewarming, there will be a profound inflammatory reaction, will cause reperfusion injury. There will be a release of inflammatory markers, such as histamine, thromboxane A2, bradykinin, and this would cause further vasoconstriction, thrombosis, and would eventually occlude. There will be blister formation as well as tissue damage and necrosis. Now, another path where patient is left in the cold, what will happen? The sequelae is that patient will eventually get tissue infarct as well as scar formation. So these are the stages of frostbite. The most mildest form of frostbite is called frost sleep, which only involves the epidermal layer. Patient would get more like reddish extremities. It will be more of painful. The second stage is the superficial frostbite, which involves the epidermis as well as part of the dermal layer. Patient would experience pins and needles as there will be patches of peeling skin. And the worst would be stage 3, where patient will involve the deep frostbite, which involves the epidermal, the dermal, as well as the subcutaneous fat layer. And these patients will have numbness. So looking at our patient at the right hand, this patient has most probably suffered a deep frostbite. So looking at the management strategy, our goal of treatment is something like burn, where we would like to salvage as much tissue as possible and achieving maximum return of function, and eventually to prevent any further complications. So I would focus on the acute treatment strategy. So when the patient was rescued at field, what can we offer to the patient? So one of the things that we have to do first is to exclude life-threatening conditions. This is back to your ABC, where we exclude life-threatening conditions and we treat it. And we have to arrange for urgent transfer to the nearest hospital, remove wet clothing, and if there is any suspected trauma, fracture, we spleen the affected area to minimize any further injury. And the important thing is to do rewarming. And at the field, what is available is blankets and towels to rewarm the patient and to administer oxygen. And there's an important caveat here. If we are not able to reach the hospital in time, or if patient is still in the freezing conditions, then there shouldn't be any rewarm, right? So once patient arrives to hospital, primary survey is done. And again, rewarming in a proper way. In the literature, it is stated that whirlpool bath is the best. What does it mean is that rewarming should be done in a circulating water. This is to prevent any temperature fluctuation. And this should be done at a temperature around 37 to 39 degrees with an antiseptic solution such as povidone iodine or chlorhexidine. And then we offer patient analgesics. The best would be NSAIDs, where not only it reduces pain, it also reduces the inflammatory response. If the pain is severe, we can offer all these opioids. Of course, definitely there will be third space loss. So IV hydration is essential. And with the immediate wound care will be, in the literature, it is stated that topical aloe vera cream, it is useful. And we also would like to perform a loose depth dressing. Antibiotics is controversial. Generally, it's not recommended. However, probably should be considered in a severe form of frostbite. So now the next question is, do we have to work up for this sort of patient? Frostbite is essentially a clinical diagnosis. However, there are certain bloods or modalities that we can offer to help in our treatment. So blood investigation is to look for any evidence of sepsis, and this would guide us in our starting of antibiotics. We have multiple imaging modalities. We can start with an X-ray. This is basically to rule out any fracture that could happen. What we like to focus is DSA, digital subtraction angiography. This would look at the vasculature of the extremities to assess the suitability for a future thrombolytic therapy. There are also other imaging modalities such as bone scan and as well as SPECT-CT. SPECT-CT gives both the anatomic as well as the functional information. This is important to assess for the extent of injury as well as to plan what is our amputation plan and our surgical planning. Okay, so for our patient, DSA was done and it showed non-opacification of the digital arteries. Okay, this is a picture not of our patient, but probably it would look something like this. What we can see in this picture is someone who has had a frostbite, and we can see that the extremities, the distal fingers are not lighted up. The vasculature stops are probably at the proximal or the middle phalanx. So another option that we can offer is that patients who have not responded to rewarming, what we can offer is thrombolytic therapy. And by means of using recombinant tissue plus venogen activators such as alteplase. And this is the same drug that we use for acute MI stroke. So what does it do is that because we know that the pathophysiology of frostbite is because of microvasculature thrombosis, it improves the perfusion by lysing this thrombus and it minimizes the tissue damage. The important caveat is that it should be done urgently within 24 hours for best outcome, and it should be reserved for those who have severe grades of frostbites. And with alteplase, what we should do is we should do a serial DSA after 12 to 24 hours to assess an improvement in perfusion. And because it is a thrombolytic, it is contraindicated in trauma or events where there is an incidence of bleeding. And if there's no improvement, it should be discontinued after 48 hours. Okay. So looking at some literature review, if you see on the your left-hand side, this is rather an old literature, but probably this is one of the first evidence to show that RTP hair has improved. Looking at the highlighted region, it shows that those who did not receive TPA, the amputation was 41%, and those who receive TPA, it was about 10%, and it was statistically significant. Another recent study, which was quite recent, about a couple of years ago, which is a meta-analysis of about 16 studies, which looked at a large sample size of about 209 patients with 1,000 plus digits at risk for amputation. And just before that, we can give this TPA either an intra-arterial or intravenous route. And they have compared the both, and it shows that intra-arterial route, it has a 76% of salvage rate, and intravenous route was 62%. And this has shown that RTPA is indeed useful in frostbite. So this is the same picture that I showed earlier on the left side. And this is pre-altiplase, and this is post. And you can see that the vasculature has improved, particularly at the thumb as well as the fourth and fifth finger. Another option that we can give is iloprost, which is a prostacyclin analog. It is a vasodilator, inhibits platelet aggregation, and this can be given a bit longer. RTPA 24 hours, iloprost can be given up to 48 hours, and some studies shows that you can go up to 72 hours. It does not require repeated imaging. These are the common side effects that could be associated with iloprost: flushing, headache, as well as allergic reaction. And some institutions, they decide, right? Either they give iloprost alone, or some of them they combine iloprost along with RTPA as well as heparin later on. And to compare both, there are actually no studies to prove one is better than the other. So it's basically based on the localized protocol. All right. So this is a nice summary, which I've mentioned. You start with rewarming, and then you assess the severity, and you would start with the whirlpool rewarming, application of aloe vera, NSAIDs, and if it is severe, we can offer iloprost as well as altiplase for infusion, and then heparin subsequently. So this is what we call as a Yukon phosphate protocol. Yukon is a place in Canada where they have extreme cold temperatures up to negative 60 degrees Celsius. So they have come up with this protocol for patients with frostbite. Okay, for our patient, IV altiplase and heparin was administered. It showed some improvement. However, of course, the duskiness, it became gangrene, and subsequently was transferred to our center from Nepal for further management. Right. So I will leave to other speakers. So thank you. This is our team. Thank you again.
Thank you very much, Mr. Hisham. I believe that was a good eye-opener for those who have not seen this condition at the hospital to be treated as a patient. We often hear about this over the media and whatnot, but having to treat this patient was an experience. So Dr. Hisham, thank you very much for summarizing and giving us an input on how this case actually presents and what can be done medically. To continue with our CPC, I would like to invite Dr. Ashraf Azhar. He is a hand and microsurgery unit in our orthopedics department in HCTM. Dr. Ashraf will now share with us the role that their unit played in managing this patient. Dr. Ashraf.
Assalamualaikum and very good morning. Thank you for having me. I am Ashraf from the hand department. So today I'm going to briefly talk about upper limb amputation briefly and what's our role in managing this patient. Sorry. All right, so there's a different level of upper limb amputation. Basically, mainly depends on level of injury, level of injury and patient demand. So there's three main indications for amputation actually. So one is dead limb, which is gangrene, then dangerous limb such as tumor or infection, and lastly damn nuisance. Basically, there's very bad deformity that make the limb become non-functional. So in terms of our patient, once the frostbite diagnosis was made, he was referred to our team, and we actually decided for amputation 1 month after referral. So what happened was we wait for a clear demarcation over the soft tissue, especially the skin. So in our patient, he actually had gangrene up till the level of MCPJ, metacarpophalangeal joint. However, after further discussion with the patient, he is a very active person and would like to go back to his usual activities such as skiing, mountain climbing. So it's very important for him to have a grip strength. So that's why we decided for actually amputation at the level of proximal phalanx, distal proximal phalanx of all fingers from index finger to the little fingers. So it's important, but to note that in amputation, soft tissue coverage is very important. So in this case, we have problem to cover the exposed bone. So that's why we also get the plastic team to help us for flap, and this will discussed by Mr. Azim later on. So as you can see from this diagram, mainly the patient had a amputation at the level of proximal phalanx. All right. So what are the complications of amputation? Mainly the main complication are infection, poor wound healing, phantom limb or phantom limb pain, complex regional pain syndrome, and joint stiffness. Early complications such as infection and poor healing are very much dependent on patient blood circulation and patient general well-being. For example, his nutritional status, special general condition, and patient, all the vital signs and everything. So then I'm going to talk briefly about phantom limb pain. So it's actually a noxious sensation where the limb still existed. So this is, we get this commonly in patients with below knee amputation, above knee amputation, or transradial amputation. Not much in finger amputation. So luckily in our patient, he did not experience any phantom limb pain. So it's usually patient will complain of burning pain or shooting pain. However, it will diminish over time and therapy. But in some rare cases, it can become permanent and very disabling for the patient. So what kind of therapy? We can actually give pharmacologic such as Lyrica or gabapentin that help with the nerve pain, or desensitization therapy or mirror therapy. So mirror therapy is basically you standing in front of the mirror, looking at your amputated limb, reminding yourself and your brain that the limb is no longer there. All right. Then the bit tricky complication is the CRPS. So it's actually a reflex sympathetic dystrophy. It's an idiopathic, which means we don't know, condition caused by an aberrant inflammatory response that lead to a sustained sympathetic activity in a perpetuated reflex arc. So basically you get this out of proportion pain over the amputated area for a period of time. So again, this can also be treated with physical therapy and pharmacologic treatment. Physical therapy is desensitization therapy with our physiotherapists and occupational therapists. Pharmacology is again same, Lyrica and gabapentin. So again, luckily in our patient, he did not develop any CRPS. However, he actually developed some joint stiffness after doing his flap because due to immobilization for 3 weeks. All right. So in this patient, because he is an active person and he wanted to go back to his usual activities. That's why level of amputation have to correlate with the type of prosthesis that is required for this patient. So there are, in this current advancement, there are multiple prostheses available. Mainly they are passive prostheses, body-powered prostheses, electrically powered prostheses, activity-specific prostheses, and hybrid prostheses. The latest one is the electrically powered prostheses, where they actually use battery. Hybrid means a combination of multiple type of prostheses in single prosthesis for the patient. So I'll show you some of the pictures. So passive prosthesis is mainly for cosmetic reason, usually in patient with low demand, with low physical activities. So they just want to have to look that the finger is still there. This one is available in our country, and yeah, you can get it in Malaysia. And as for our patient, since he is an active person with doing a lot of physical activities, we actually opted for body-powered prosthesis for this patient. So from what you can see, the picture shown by Mr. Azim later, our patient will have similar stump as the picture on the right-hand side. So basically, this is what we call a MCPJ driver body-powered prosthesis. The residual muscle over the proximal phalanx and the MCPJ will help the fingers to flex, so patient can actually grip and actually do heavy stuff. This body power prosthesis is very durable, very strong, and you can actually change colors depending on your favorite color. And in the middle, just for knowledge purposes, the body powered prosthesis can cost about 20 to 40K depending on the material that you use. Unfortunately, it's still not available in Malaysia. The latest one is actually the myoelectric prosthesis, which is in the middle there. So this is battery powered, with sensor that you can, and they almost replicate the function of your hand. However, why this is not suitable for our patient, because it is not as durable as the body powered. You cannot use it outdoor, especially if there's any rain or any lightning. Because it's battery powered, there's a risk of it. It stopped working in the middle of your activity, and it's cost you about 200K minimum. So that's why, yeah. So based on the processes that we decided on the patient, that's why we do the amputation at the level that is suitable for this prosthesis. So I'm just going to show a quick video. Okay, this is from the company, not promoting, just to share what this prosthesis can do for the patient. So yeah, this is something that's going to be used by our patient later on, inshallah. All right, I think that's the end of my presentation. So basically, in summary, our role in this patient is actually so in upper limb amputation. Frostbite is a disease of mobility, so it's our role as doctors to reduce the mobility of the patient. So the aim is to allow the patient to go back to their activities as much as possible. So it's important for you to have a chat with the patient, gauge their expectation, and from there decide on the best course of treatment for the patient. All right. So thank you very much for having the hand team inviting us to give some talks on amputation and prosthesis. Thank you.
Thank you, Dr. Ashraf. A very interesting presentation indeed. To see how prosthesis and this technological advancement can improve fine and gross motor for patient who has lost their fingers in this case. So in order to fit those prostheses, we need to prepare those affected hand to be fitted onto those. So for that, to share our experience in our hospital, we have with us the head of our plastic, Dr. Azim Poh. He will now share with us on how was his journey in treating this patient. Dr. Azim.
Thank you, Dr. Kishen. Okay, I'll share my screen. Okay. Okay, good morning, everyone. First of all, thank you to Vaskular team and hand team for inviting me to be involved in the management of this patient. It's a unique experience indeed. So, okay, so I start my presentation with this simple maxim or credo, which was stated by one of the forefathers of hand surgery, Sterling Banner, who says, "For those who have nothing, a little is a lot when it comes to hand patients." this seemingly benign statement is actually is a strong guiding principle which has been echoed until now in our hand textbooks or even class history textbooks. Okay. So the principles which we were adhering to this management of this patient is, first of all, we want to salvage as much as possible whatever viable tissues there are. And we anticipated from early on that there's going to be exposed bone, so we need an adequate soft tissue closure, which first of all to cover the separate stumps, and we needed the soft tissue closure to provide adequate padding, some restoration of function, hopefully with the future prosthesis. And even let's say he does not have that prosthesis, any stump will be useful for a patient. For example, he can adduct and hold objects in between his digits, and put a question mark down aesthetics, because it's not that easy to achieve aesthetics in this particular case. So the guiding principle for us is always the reconstructive ladder. I think some of us are familiar with it, right? And in all these options, we were brought down to the decision of either a free flap or a distant flap. And so, however, we have the challenges of vascularity, because as we remember, the patients had a compromised capillary level vascular problem, and also because of his age, we always have to be suspicious of any other medium-sized artery level compromise. And also remember the point that they had to give him some thrombolysis. So we were also buying time to see whether more and more capillaries would open up with time. So we needed to get adequate tissue with minimal donor morbidity. So therefore, the decision was initially to have an adjunctive treatment with a hyperbaric therapy, which I believe Dr. Andrew will be presenting after. This mainly to be an adjunct to improve further the circulation, which is already compromised. We want, so to speak, we want to have a more tissue available to us, because in this kind of scenario, and a little means a lot. And so our decision was to have a two-stage abdominal flap. This is a very traditional flap since decades ago. I believe it's more than 100 years ago. And eventually, with this flap, we need to syndactylize the digits first, because they are so close to each other. Therefore, we have to apply the soft tissue together first, and with further stages of separation of the digit surgery. So this was the patient when we first saw him, and he was ongoing, having some hyperbaric therapy, and you can see that the dry gangrene, which was initially shown by the previous presenters, is now is showing to be more wet now, and at the risk of infection soon. So this eventually the hand team, our co-managing team, they debrided and amputated to this level. So this is the proximal digits, and the distal part of proximal digits, the joints of the PIP, the proximal interphalanx, were somewhat excised off too. Okay, they had to. This was the best we could achieve at that time, because we were guided by clinical bleeding on table. Okay, as you can see, all five were left with just mere stumps of the proximal phalanx. So we proceeded with planning where we're going to apply the abdominal flap. We position first at the comfortable position, because the patient is going to be in this position in about 2 to 3 weeks. So he must be comfortable for the shoulder. He allows some mobilization of the shoulder to avoid stiffness of the shoulder. So that was my initial drawing. It's actually a bit erased by the Pembedaan eventually. So that represents the flap which we were going to design. So we raise at the level of a suprascapal level, and the abdomen. Remember, we have the subcutaneous and the scarpa's fascia. All right. So that was the flap when we raised it all, and later on we fix it on. We actually, even though you can see from this picture, this whole flap has encased both the anterior surface, the volar surface and the dorsal surface of the hand. Encased all the way to the viable skins which were left behind. So this is the end of the surgery where we grafted the donor side too. Okay, and okay, after a few weeks, after 2 weeks actually, because I wasn't too confident in this case whether the vascularity was adequate. So we take advantage of this phenomenon called the delay phenomenon, where we choke the flap a bit more. So if you can imagine, the blood supply of this flap is all solely coming from the lower abdomen there. So usually, from what we know from previous studies, there will be axialization of the capillaries which are random here, which are randomly travel in the skin. They are now more. They should be more axial, which travel from the abdominal wall to the hand. So to further enrich this axialization, to form more axialization, so that now more of it will be formed on the hand rather than the abdominal wall, we choke it. So if you can compare to the previous picture here, which is the flap has a broad base. In this picture, it has a more. We eventually incise it in the ward with some local anesthesia. We incise bit by bit just to choke it, just to have the ischemic stimuli to encourage more axialization in the flap coming from the hand. Okay, this is a very well described phenomenon when it comes to flap surgery. So this was 3 weeks after we elevated everything from the abdomen, and the flap blood demonstrates good bleeding. If you see that on the volar surface, there is some raw subcutaneous fat, but actually it has covered the bone very well. It has provided a very good padding there. It's covered all the way to the skin. Yeah. Retrospectively, I could share that I should have raised more skin so that it would just cover the whole surface. But that time, the choking, I think it was a bit too proximal for this. But anyway, we managed to close everything eventually. This was a few more weeks after, and all the flap has survived with some scarring, some scabs. And eventually, last week, actually, we syndactylized only the third web space. We separated the third web space. You can see the web space is still nice and clean and viable. And that's the raw surface. No bones were exposed. And on palpation, we still have a very nice padding of the fat. Okay, we harvested a chunk of full thickness graft from his groin, and we stitched it onto the raw surface of the syndactylized surface, and there it is. Okay, so this was him on table. He is due to come again this week to review the skin graft take. All right. So all this is to actually again to have to provide the stump. That's why I put the question mark on aesthetics. I don't think I could achieve better aesthetics than this, because I was trying to get the padding. I was trying to get the enough coverage for all the individual digits. So, but on the other hand, I think I achieved that function, and hopefully the future processes will fit later. This is not finished, by the way. It's not a finished product. We plan to separate all 4 digits later. We did not dare. I mean, not you. I mean, my team. We did not dare to separate all at this stage because, again, we always have to be wary of the vascularity. So this step also is considered a delay phenomenon, which will enrich further more blood supply from the index and from the little finger areas. Okay, and hopefully eventually this is not. This is also a picture taken from the net. Hopefully, his thumbs will be ready to take on this kind of processes for function, right? Okay. So, and let's say he did not go for this too. These thumbs, like I said, it's going to be useful for simple tasks like pressing on a switch, light switch, power switch, or you can even fit in a pencil in between or something to grip in between. Hopefully not a cigarette. Okay, and sorry. So other than that, I guess I'm obliged to also share what other options are there to reconstruct digits. So there is this toe to finger transfer, which I've assisted before in my training during when I was in USM, our plastic surgery training. Yeah, I've assisted before in this kind of surgery, toe to finger transfer or toe to thumb transfer. It's not that simple due to the fact that the blood vessels are tiny. It's about 0.5 to 0.8 millimeters. So it's considered super microsurgery. And nevertheless, but in this patient, it wouldn't have been a good option due to the questionable vascularity again. Okay, another example of a toe to thumb reconstruction. These are not my patients, but we have witnessed this kind of case before in USM. Okay, so my closing slide is a picture of this surgeon from 500 years ago, Gaspare Tagliacozzi, whose family initiated this idea of distant flap surgery by reconstructing the nose with a tissue from the arm. So with that, I thank you. Let me unshare this.
Thank you, Dr. Azim, for a very interesting presentation. I think we're running out of time, so without further ado, I would like to invite our invited speaker, Dr. Andrew Ng. He is a staff anesthetist and also the head of the Malaysian Armed Forces Diving and Hyperbaric Medicine Services. So indeed, it's our great pleasure for us to have him with us today to share how the services that they provide can aid in the treatment of frostbite. So without further ado, I would like to invite Dr. Andrew Ng.
Thank you so much, Dr. Kishen. Thank you, everybody, for inviting me to this CPC or CME. My job today is to give a little brief overview of hyperbaric oxygen therapy and a little bit into using it in frostbite. I have to admit, this is probably the first case of frostbite using hyperbaric oxygen therapy in Malaysia. So what is my outline? That's what I'm going to tell you today regarding mainly more what is hyperbaric oxygen therapy, because there's not a whole lot of very strong evidence in terms of what you call large trials for hyperbaric oxygen therapy for frostbite. So hyperbaric oxygen therapy is an intervention in which an individual breathes 100% oxygen at increased pressure. So anything above 1.4 ATA, atmosphere absolute, you can consider it a hyperbaric oxygen therapy. However, usual treatment pressures are above 2 ATA, where we consider it to be more effective. So as a hyperbaric physician, we consider oxygen as our drug. And with all drugs, there is a dose and a prescription. So for example, the dose may be 100% oxygen at 2 atmosphere, and the prescription could be different tables. We call it tables where we prescribe, if you look over here, how many minutes of oxygen, air breaks, and how deep we want the patient to be. So this is what I will tell my chamber operator what I'm prescribing. And then, of course, with all prescription, there is the how many doses, BD, TDS, and so on. So it could be daily, twice a day, and the number of treatment needed, the duration of the treatment. So this is a common table that we use, 14 meters table. We dive the patient to 14 meters depth, obviously not using water, we use pressurized air. And then the patient will stay at that depth for 90 minutes with intermittent air breaks, and then finally coming back up to the surface. So how is it delivered? You have both two types of chamber. One is monoplace chamber, where only one patient can go inside. The advantage of this is cheaper to procure, but the disadvantage, if you can see, there is nobody inside with the patient. They have to be alone, and if there is any emergency, it may be a little bit difficult to get to the patient. So the other chamber is multi-place chamber, where you can put more than two or more patients inside. And this is the chamber in Lumut, our Institute of Underwater Medicine. And you can see you can ventilate patients, you can take care of very sick patients, and that's the advantage. Of course, the disadvantage is the cost to have a multi-place chamber is much higher. You can deliver oxygen besides intubating a patient. The usual way is giving it via a mask or a hood. This is not hyperbaric oxygen therapy. Just want to stress, there are people giving ozone therapy, things like this inflatable balloon where you can buy it off Amazon, but that doesn't deliver enough oxygen. If you're going to do this, might as well just breathe oxygen off the from a tank or from a wall. And this does not deliver enough oxygen. If this works, then probably we don't need a nose. We can all absorb oxygen through the air. So how does hyperbaric oxygen therapy works? There's three main mechanisms. Number one, bubble size reduction. This is pure physics, Boyle's law, whereby increase in pressure will reduce in volume. And the other two is through increase in oxygen delivered, either by restoring normoxia or reversing the hypoxia, and also there are effects on gross hyperoxia. So just a summary of the various mechanism of action that have been proposed. I wouldn't have time to go through each of it, but basically for pressure is the bubble reduction, for example, in decompression sickness, in diving, or gas embolism, iatrogenic, for example, in neurosurgery, setting of your central lines and so on. And in reduction of hypoxia, you have things like wound healing, crush injury as well. And high oxygen have actually various modalities or what people think how it works, including hyperoxic vasoconstriction, helping in growth factors formation, stem cell mobilization, and other factors. So in terms of indications of hyperbaric oxygen therapy, for us in the military, we strictly follow the Undersea and Hyperbaric Medical Society. This is the largest hyperbaric medicine society in the world in US. And every 5 years, they publish a book on indication, which they think there is enough evidence and the insurance company in US will pay. So the latest edition is 14th edition. The 15th one is coming out, I think, either this year or early next year. And you can see the 14 indications that we follow. So the one that we treat a lot here in our center includes things like problem wounds. A lot is coming up are the delayed radiation injuries, whereby you have things like osteoradionecrosis, radiation cystitis, and so on. So about 40% of my patients are delayed radiation injuries. The other 50% is problem wounds like diabetic foot ulcers. And of course, it can also be used for as an adjunctive for like such a case like this in the frostbite for arterial insufficiency, maybe a bit of compartment syndrome included, you know, and acute trauma in this frostbite case. So frostbite pathophysiology have been covered, basically cold and causing destruction of the tissue. And when you rewarm, there is a reperfusion injury, causing a lot of damage to the vasculature as well to all the soft tissue. This is a picture of the frostbite. It's already been shared earlier. So for hyperbaric oxygen therapy for frostbite, unfortunately, I mentioned at the beginning of my talk, there is no randomized control trial, but there are a lot of multiple case reports and case series. Most of the time it's used in combination with other modalities, as mentioned earlier. But occasionally he has been used as a monotherapy, and the possible mechanism of action and how hyperbaric oxygen therapy works or help as an adjunctive for frostbite is a reversal of hypoxia, and also in terms of reducing inflammation and reperfusion injury. So those that is interested, you can have a look at this, the mechanism and efficacy of hyperbaric oxygen therapy by Tom. And there will be quite a lot of information on that and how it actually reduces inflammation and helps in reperfusion injury. So there are tons and tons of case reports and case series, even since the first reported use of hyperbaric oxygen therapy in 1963. And you can see here the whole list of using it for acute as well as delayed presentation. So a summary of all those evidence or recommendation by various societies says that you need at least 2 atmosphere of pressure and at least 90 minutes of hyperbaric oxygen therapy twice daily, at least for the first few treatment, and then once per day. On average, it needs about 10 to 20 sessions. So the evidence seems to suggest that earlier you start hyperbaric oxygen therapy, it will give you a better outcome. But even those that have been delayed up to 3 to 4 weeks, there are some with some good outcome as well. And the aim is to preserve tissue so that the surgeon, the plastic surgeon, the hand surgeon can do their work better. And it helps to demarcate what are the viable tissues and what are not. So again, helping in planning the surgery in terms of what can be done, what level of amputation. For this patient, came to us, I would say, a little bit late. I think it was about a week plus since the incident. By the time he was stabilized for a couple of days in Nepal, and then transferred over to HUKM, the referrals, and so on. It's about a week plus, if I remember correctly. And we started almost immediately. He was a fit, healthy person, so there was no contraindications for hyperbaric oxygen therapy. He had a bit of interrupted sessions. We were not able to do a full 10, 20 sessions. We did about 7 or 8 sessions, and then it was interrupted by some surgery and so on, and he came back again later. So you may be asking, what are the contraindications for hyperbaric oxygen therapy? Basically, there is only one big absolute contraindication, which is untreated pneumothorax. So if anybody with pneumothorax, we need to put in a chest tube before putting him in the chamber. Otherwise, most of it are relative. Things like uncontrolled asthma, because you can actually cause pneumothorax with the expansion of gas when the patient comes up to the surface. Claustrophobia, patient will not go in. You have eustachian tube dysfunction, things like URTI or more permanent eustachian tube dysfunction, then the patient cannot clear his ear or equalize his ear doing Valsalva, so you have pain when going inside the chamber. So based on that contraindication, this some of the risks and side effects of hyperbaric oxygen therapy. By far, the most common is barotrauma to the middle ear, and you get this bleeding or even rupture of the eardrum if you do not clear the ear properly. So about 15%, up to 15% of patients may have middle ear barotrauma. Others include sinus barotrauma, dental and pulmonary barotrauma. And the other risk is oxygen toxicity. So we limit the depth that we go to up to 18 meters, which is 2.8 atmosphere, because higher than that, then the risk of oxygen toxicity to the brain increases, where patient gets unconscious of seizures, which is reversible. And more longer term, you may have pulmonary oxygen toxicity. This usually happens after 50, 60 sessions of hyperbaric oxygen therapy. And for some reason, the eye will have changes as well with increase in oxygen, which is hyperoxic myopia. And finally, with diabetic and elderly, they may have hypoglycemia from the increased oxygen, which the cause is still debated. The most dangerous risk will be fire and explosion, which have never happened in Malaysia. We do not want that to happen. But the most recent one, which had fatality, is back in 2016 in Jakarta, where 4 patients died because of the explosion. So in terms of referral for hyperbaric oxygen therapy, these are some of the chambers you have in Malaysia. We have 3 hospital-based chambers in the military, one in Lumut, one in KL, and one in Kota Kinabalu. We accept referrals from all military, civilian, and even foreigners. There is a monoplace chamber in HUN Kubang Krian. There is also a chamber in MSU in Shah Alam. And there are some private chambers in Sunway, Taman Titiwangsa, and also in Penang. So that's all for me. Thank you so much. Any questions, I'll be happy to answer.
Thank you, Dr. Andrew. Very informative lecture. There is one question, if we can take before we end the session. There is from Aznida Firza. Since the patient expressed desire to resume his mountain climbing and skiing activities, what preventive measures can we advise him to prevent recurrence in remaining limbs? So I open this to the panels. Who wants to take this question? Probably Dr. Andrew.
Okay, I guess, yeah, he did say that he wants to go, again, this is his third attempt. He have not reached the summit, and he's going to try again. And I think this next mission is going to the South Pole or North Pole or somewhere. He's a very, very active person. I mean, the only way is to prevent frostbite is to protect from the elements. So yeah, so that is the thing that he had to do. I think the reason why he got exposed this time because of some trouble reaching the summit, and he got exposed. And usually when frostbite happened, from what I read, it's quite insidious. You wouldn't know, and by the time you know, it's already too late. So the only way to prevent is to have proper cover, proper glove, and do not open the glove when when you are at that extreme negative temperatures.
I would say that he'll be challenging the reconstructed site too. Actually, when he does this, it's a very high risk activity that he's going to take. The flap, even though if it survives after a few months or maybe years, is still not as good of a vascularity as our original native tissue. The only thing to prevent is not to go at all, but if he still desires, he needs to consult with other experts of his altitude sports, altitude sciences, how better to prevent his to keep his temperature regulated at those extremes. I really can't offer any positive advice actually, other than asking him not to go actually.
I think he wanted to go this January. I think Azim, he was telling us want to go for ski, so that's why we told him not to go.
Yeah, because if anything happens again, to salvage it, it won't be as easy as it is now. It's not that easy in the first place, but at least it's doable. I foresee more challenges if anything happens.
Okay.
Good morning, Dr. Kishen. May I ask a question?
Prof.
Hello, Dr. Kishen.
Yes, please go ahead, Prof.
Yeah, this is to Dr. Andrew. Thank you so much for your presentation, Dr. Andrew. I'm Prof. Amara. I'm a rehab physician here. So regarding the hyperbaric oxygen treatment, so one of the issues with hyperbaric is also the release of ROS and RNS, free radicals, which can also overwhelm the body sometimes. So is there a role for nitric oxide based food nutrition, or even supplements like citrulline and arginine that can help to clear some of the ROS?
I'm not too familiar with that kind of food, but what hyperbaric oxygen therapy does is actually reduces all these reactive oxygen species and reactive nitrogen species. It's actually a positive effect rather than the negative effect.
Okay, it's just that my understanding is also that there is a release of these free radicals, which some of it can get can improve with the oxygen therapy, but the residues is what sometimes cause them to feel not so well after that. So whether making sure that the free radicals are cleared completely would be an option to, or an adjunct to, the management.
I'm not sure, Prof, to be honest, but most of our patients feel much better after hyperbaric oxygen therapy. I'm not sure that it's more of a psychological effect, but when you ask them, they come, are you all right? Most people don't have any, just feel normal, but some say, oh, I feel very energetic after hyperbaric oxygen therapy. I guess it's more psychological.
Okay. Thank you.
Thank you for the question, Prof. I think we are almost hitting 9 a.m. I would like to conclude this CPC in the usual manner by thanking all speakers for an. I hope the medical students and others present in this CPC had benefited somewhat from the topic that we chose to present this time around. So once again, thank you very much, and see you all in the next session.